everyone, my name is Christina Sanabria and I did my comprehensive case study on a patient with Crohn's disease. The objectives for this presentation is to introduce the patient, discuss the pathophysiology and etiology of Crohn's disease, other medical concerns, current evidence for current nutrition practice, the actual nutrition intervention and prescription, and then the discussion and conclusion, as well as references. Here I will provide a synopsis of the patient's clinical course during her inpatient stay. The patient was a 54-year-old female admitted to the hospital with the diagnosis of Crohn's exacerbation and new onset of diabetes mellitus 2. The patient received total parenteral nutrition before agreeing to a PEG placement. TPN was discontinued and enteral nutrition support therapy was initiated. The patient was later discharged and readmitted 3 days later with the diagnosis of abdominal pain due to enteral nutrition infusion intolerance. During the length of her stay, the nutrition goal was to establish GI tolerance to enteral nutrition therapy in order to provide adequate nourishment based on the patient's estimated energy and protein requirements. The patient had a medical history of Crohn's disease with a partial colectomy and ileal pull-through. She has osteoarthritis, vitamin B12, and iron deficiency, as well as a PEG placement. The patient was diagnosed with Crohn's exacerbation and new onset of diabetes mellitus 2 upon her first admission to the hospital. She was also evaluated by a speech and language pathologist and diagnosed with acute oropharyngeal dysphagia. After discharge and readmission, she was diagnosed with GI distress, including abdominal pain, nausea, vomiting, and diarrhea secondary to Crohn's exacerbation. This is a picture of Crohn's disease with a comparison to a normal functioning GI tract. And I like this because the inflammation is clearly shown in the bottom box right here. The pathophysiology of Crohn's begins with an inflammatory immune response that causes cell damage characterized by malabsorption, ulceration, and strictures, among with other GI abnormalities. And this can usually be diagnosed with signs and symptoms including diarrhea, weight loss, and abdominal pain. Although the exact etiology of Crohn's disease is unknown, research suggests a strong genetic susceptibility to the condition. Both environmental and exogenous triggers activate an immune response in the intestinal mucosa. However, the oral cavity to the anus can be affected as well. And all of these contribute to irritable bowel disease. Along with the patient's Crohn's disease, additional medical concerns impacted her nutritional status and decreased oral intake. And interestingly enough, it also impacted her insulin resistance. These concerns included severe dysphagia, vitamin B12 deficiency, iron deficiency, GI distress, including nausea, vomiting, and diarrhea, oral candidiasis, and diabetes mellitus 2. Current evidence for nutrition practice is validated by extensive research of Crohn's disease. I'll highlight some of these details. Nutrition should be used as a primary therapy in management of Crohn's disease. Protein energy malnutrition in patients with Crohn's are associated with increased length of hospital stay and in-hospital mortality. Malnutrition in patients with Crohn's is common. 65 to 75% of inpatients are estimated to experience weight loss. And nutritional support should be provided by oral or enteral means whenever possible. Current research pertaining to Crohn's disease support the need for nutrition intervention. Malnutrition remains the primary concern for these patients, affecting, as mentioned, 65 to 75% of inpatients alone, which is significant. And upon the patient's admission, a reported weight loss of 30 pounds in 2 months was documented, providing an indication for nutrition support, which she ended up receiving enterally. Further research has shown enteral nutrition to initiate remission in patients, stimulate gut motility, and help restore microflora. Enteral nutrition may also help limit steroid use, which is known to have long-term side effects with extended use. Just to highlight the most common medical and nutritional interventions, probiotic and prebiotic use, steroid use, along with nutritional support. And interestingly, nocturnal tube feedings have been shown to increase weight gain, suppress GI inflammation, and induce remission during flares. According to nutrition guidelines, estimated requirements for patients with Crohn's disease are based on the patient's BMI. In this case, the patient had a BMI of 18.8, but was visibly malnourished and at risk for refeeding syndrome. Protein was based between 1 and 1.5 grams of kilograms of body weight, and that was monitored and adjusted as needed throughout her inpatient stay, along with adequate fluid needs. Crohn's patients are at risk for vitamin and mineral deficiency, including vitamin B12 and folate, fat-soluble vitamins, zinc, iron, calcium, magnesium, and selenium. And due to the increased malabsorption issues, multivitamin and mineral supplements are often recommended. The patient received ferrous sulfate along with the multivitamin supplement during her inpatient stay. The recommended nutrition prescription began with the initiation of Vital 1.5 at 20 to 25 milliliters an hour, with an additional ProSource TID. This was later revised. Glucerna 1.2 at 20 to 25 milliliters an hour with additional ProSource TID was initiated. However, patient complaints of persistent abdominal pain, nausea, and vomiting prompted provision of the above formulas. An isotonic formula was chosen to increase GI tolerance. Osmolite bolused at 250 milliliters 2 times a day, and nocturnal continuous feeds at 25 milliliters an hour with additional ProSource TID was the patient's final nutrition prescription before discharge, and this provided the patient with her estimated requirements. Throughout the patient's stay, additional nutrition recommendations were made by the dietitian, including the consideration of J-tube placement due to her GI intolerance, as well as probiotic use. And these recommendations were discussed with the patient's physician, and a probiotic was ordered, however, a J-tube was never placed. The specific probiotic recommended was Florastor. This slide is a comparison of nutrition guidelines and interventions, and while comparing the course of intervention and nutrition practice guidelines, I found that the interventions for Crohn's disease closely followed the nutrition care process, and I'm confident the nutrition prescription was suited to deliver optimal nutrition therapy during the course of the patient's hospital stay. Although not every intervention was ordered, the nutrition recommendation was there. And Parenteral nutrition should be considered only if enteral nutrition has failed. TPN was ordered before enteral nutrition was initiated upon the patient's first admission. However, the dietitian was able to discuss the benefits of enteral nutrition over parenteral nutrition, and the patient actually agreed to a PEG placement. However, the patient's GI intolerance continued and was persistent, so a J tube was recommended. However, that was never ordered. But per guidelines, the post-pyloric tube feedings may be indicated for patients who do not tolerate gastric tube feeds. A probiotic was recommended and ordered, and the guidelines say that alteration of the intestinal microbiota can have beneficial effects when using enteral nutrition as nutrition support. Lastly, although the patient's recommended requirements for her BMI of 18.8 was actually 30 to 35 kcals per kilogram, the dietitian used her clinical judgment because the patient was at risk for refeeding syndrome, and therefore the estimated energy requirements that were recommended were 25 to 30 kcals per kilogram. In conclusion, the patient was discharged from Columbia Memorial Hospital to a nearby nursing home at which she would continue the final nutrition prescription. She would receive continuous nocturnal feeds via her PEG tube of osmolate at 25 milliliters per hour with 250 milliliter dual bolus and an additional 1 pack of ProSource 3 times a day. The patient was, however, unable to reach her goal during her inpatient stay. The patient's diagnosis of acute oropharyngeal dysphagia was also not resolved during her inpatient stay. The patient has not since been readmitted. These are my references, and thank you everyone for listening.